Welcome to Global Connections with Robert Siegel, Navigating the New Normal, presented by the American Friends of Rabin Medical Center. Our monthly Leaders Forum addresses vital issues facing society and the economy, real estate and technology, medicine and science. My name is Dr. Joshua Plout. I'm the Executive Director of American Friends of Rabin Medical Center, AFRMC, a 501c3 National American Charitable Organization based in New York City. We at AFRMC represent Israel's premier hospital, Rabin Medical Center in Petah Tikva in Greater Tel Aviv, the leading institution named in honor of Prime Minister Yitzhak Rabin. The hospital is a model of coexistence. It serves 1 million patients annually from all ethnic and religious backgrounds with the same compassionate care. We would like to share an overview of the work being done at the Rabin Medical Center.
Rabin Medical Center, located nearby Tel Aviv, is one of Israel's largest and most advanced academic hospitals, named after former Israeli Prime Minister and Nobel Prize winner for Peace Yitzhak Rabin. Comprising Bellinson and Hasharon campuses, it has been a national leader in medicine, science, and compassion towards patients since its founding in 1936. As the flagship hospital of Israel's largest healthcare provider, Clalit, with more than 8,200 dedicated staff members, RMC gives treatment to around 1 million patients every year, performs more than 70% of all organ transplants, and provides health care to every 6th cancer patient in the country. RMC is a home for internationally acclaimed centers of excellence, including Davidoff Cancer Center, Samueli Institute for Cancer Research, and a new brain and heart center, the Tower of Hope. Through groundbreaking research, AI-driven medicine, cutting-edge technologies, and global collaborations, RMC is redefining what is possible in modern healthcare. In moments of peace and in times of war, we stand on the front line. As a main trauma center, RMC is healing soldiers and civilians, reuniting families, and strengthening the Israeli social fabric and resilience. Delivering not only world-class treatment, but also human connection, healing, and hope. Rabin Medical Center, a beacon of innovation, excellence, and care.
Our host and moderator for Global Connections is Robert Siegel, former host of All Things Considered on National Public Radio for 31 years. Over the course of an hour each month, Global Connections features guests who Robert Siegel interviews as they explore important issues in our world. Today's Global Connections topic is medical innovations in artificial intelligence. Thank you to our very special guest, Dr. Susan Domchek, Executive Director of the Basser Center for BRCA and Director of the McDonald Cancer Risk Evaluation Center. Dr. Eric Topol, Chair of the Department of Translational Medicine and Director and Founder of the Scripps Research Translational Institute. And Dr. Michael Bahar, Director of the Rehabilitation Department at Israel's Rabin Medical Center. And now, Global Connections with Robert Siegel.
Thank you, Josh. The advent of artificial intelligence has created an age of great expectations. The stakes, we are told, are colossal, change of historic dimensions, something on the scale of the Industrial Revolution, some say. Who knows how many years it'll be before the factory worker, the taxi driver, the voice actor, the teacher, and the radiologist will all be working in novel, unrecognizable ways with computers taking over some of the heavy lifting. It's that last worker, the radiologist I mentioned, who interests us today. How doctors do their jobs affects us all. And the possibility of new cures and therapies derived with help from AI makes even the development of a self-driving Uber pale in comparison. How is AI changing medicine? Are patients already benefiting from AI, and what's reasonable to expect in the way of progress? To address those questions, we've assembled a remarkably interesting panel. Our first panelist, Dr. Eric Topol, is especially qualified to provide us with some context here. He has confronted the coming impact of AI on healthcare in multiple ways. He's a cardiologist. He's the head of translational medicine at the Scripps Institute in La Jolla, California. And if for you, like me, translational medicine is an unfamiliar phrase, I read that it's about translating basic science into medical practice. Also, Dr. Topol has written books about medicine. One of them, Deep Medicine, is all about AI. And his most recent book is Super Agers, an evidence-based approach to longevity. Eric Topol, Dr. Topol, welcome. Thanks very much for joining us today.
Thanks, Robert. Good to be with you.
7 years ago, when you wrote the book Deep Medicine, you were disappointed with the pace of change, and proven successes were not nearly so great as the phenomenal claims that were being made for what was in store. When you survey the field today, a few years later, do you see significantly more successes, and has the pace picked up sufficiently?
Well, it's starting to pick up. I mean, what we're seeing, of course, in outpatient clinics throughout the U.S. is more and more use of ambient conversations to not just generate an automated note, but also decrease the burden of physicians, clinicians, for many of the other tasks that are data clerk work, such as the need to schedule appointments and labs and procedures and pre-authorizations and all those sorts of things. So in addition, there's ability to nudge the patient through AI subsequent to the visit to capture some of the data or results of what was discussed, of patient symptoms and so on. Now, that's one area that is making good progress.
Mm-hmm.
And it's nice to see because there's been randomized studies to validate that it's working, that it's improving morale, that it's decreasing data clerk work for clinicians, and patients have higher sense of fulfillment because the doctors are actually talking to them, have a presence, and not focusing on a keyboard and a screen. The second area that has progressed substantially since that 7-year time gap is the accuracy of medical image interpretation. And so we do know that whether it's any type of scan or the retina or electrocardiogram or path slides, we can get far more accurate and comprehensive interpretation through AI tools that we didn't have before. But there's still a long way to go,
Yeah.
Robert, for many other areas.
You have written about a nexus of problems, great demands on a doctor's time to do the kind of clerical work that you say some are being now liberated from thanks to AI, interactions between doctors and patients that are very brief, and you would say high rates of bad diagnoses, but also high rates of doctor burnout. Should we expect AI to solve all those problems?
Well, we probably won't solve them, but I think it's going to contribute to improving all of them. One of the big surprises for me, Robert, was when I wrote that book, there was a chapter called Deep Empathy.
Mm-hmm.
And I never envisioned that AI would promote empathy because it has no idea what empathy is, of course.
Mm-hmm.
And what we're seeing is that the ability to channel empathy and communication sensitivity. And it wouldn't be at all surprising to me over time that physicians will get coached by AI and they'll look through the automated note and say, well, Dr. Jones, why did you interrupt Mrs. Smith after 8 seconds. She never got a chance to express her concern and other things like that. So there have been 13 studies that compared doctor empathy versus AI empathy. And 12 of the 13 studies all showed that the AI was better for exuding empathy. I would never have predicted that.
You- yeah.
Yeah. So
You also wrote about obviously fields that are involved in imaging and recognition of patterns are the most obvious fields to be changed in the coming time by AI. That would include radiology, pathology, and you include dermatology, which I would never have thought of. But you also found that for even in psychiatry,
yeah.
what you just described has also been found, which is people preferring to talk to a machine than to a human. Even if they're told there's a human being behind the machine, they'd prefer the machine without the human being.
Yeah, that's extraordinary. And now the chatbots and generative AI are building on that because, um, as we've learned, people's most precious secrets are they're unwilling to talk to another human, but very receptive to talk to an avatar or a chatbot. Now, the worry there is one of the big concerns across the board for AI, and that's about privacy and security of data.
Mhm.
There are many others on the list, of course. That's just one of the concerns. But the mental health story is such an important one because we're so short on professional staff to support people with depression and other mental health concerns. And this, if it clicks, which we're still in the early phases of getting validation, could be a really great improvement to support people. And especially because of the willingness to confide real deep concerns that otherwise would not come out with a therapist.
Uh, I mentioned that the radiologist is obviously one of the most affected specialists in this time of AI's arrival. I was stunned by the volume of images that a radiologist reviews and the amount of time the radiologist has to look at every image. I mean, these numbers are staggering. You can give us some sense of that.
Yeah, no, these what people don't realize is when you have a MRI or CT, there could be hundreds of different files to review of this angle, that angle, and the motion, and it's very consumptive. And the expectation for radiologists is reading a huge number of scans per day. Uh, So that, of course, can be facilitated through AI. But one of the important things we'd never want to lose is that oversight by an expert. So AI will speed things up, will improve productivity, will pick up things that a radiologist might miss. But then these are serious matters for patients, and they do need to have that expert oversight. So we never want to lose that part of medicine. And that's, of course, the concern is that we could go to autonomous mode, like a Waymo vehicle,
Mhm.
certain specialties. That would be really deplorable.
When you say that we're now picking up on things in images that people didn't see before, that's not just that it's a higher resolution image, is it? It's also that the uh, the AI machine doesn't get tired. It doesn't,
Yeah, it's a little bit of that, but mostly it's that it sees things that we can't see.
Mhm.
It has a higher resolution by many fold. So if you take any form, like for example, a chest X-ray, one of the most common scans performed throughout the world, it picks up the calcium score of the coronary arteries accurately and preempts the need for a CAT scan to do the same. It will it will tell us everything about valve leaks, about every size of the chamber, the ejection fraction. It even will tell us if someone has pre-diabetes from the chest X-ray because it analyzes the mediastinal fat pads. So there's all these things that humans can't see The retina is the richest of all. It's the gateway to every part of the body. The best retina expert could not tell you about the chance of a person developing Alzheimer's disease, Parkinson's disease, liver disease, kidney disease, a heart attack, stroke, and on, no less their blood pressure control and their diabetes control. So what we're seeing is a revolution in image interpretation. The term that's frequently used, Robert, is opportunistic. That's kind of a maybe not the right term, but the point being is that AI sees things that humans will never see. And it does it pretty darn accurately. And in China, for example, they've already started using chest and abdominal CT scans to pick up pancreatic cancer that the radiologists miss. It's an algorithm they've published on and validated called Panda, and it's now becoming routine throughout the country of China to pick up early pancreatic cancer that is frequently being missed in most other parts of the world.
The example of AI being used to look at a chest X-ray and make it unnecessary to have a CT scan.
Yeah.
That's the one thing you've mentioned that saves money. That is, is that typical of AI, or are we looking at a more expensive age of medicine that indeed is more effective, but still more costly than what we have now?
Well, I mean, we have to build on these revelations. So, for example, the retina, someday we'll all be taking retina selfies with our smartphone and getting AI interpretation. And it'd probably be more helpful than, for example, a hemoglobin A1C or taking lots of blood pressures because it can see how well those two aspects are being regulated by our lifestyle and if medications are being used. So there's pieces of this that are new that have to be built on to make this even more economical. You've given one example. There are many others. So, for example, a mammogram. We can get all the risk about the heart disease from the mammogram. That saves a lot of workup of heart disease, but we're not using it. No less than the mammogram that we can pick up in a normal mammogram called by expert radiologists. AI can pick up serious risk of cancer in the next 3 to 5 years. That would put the person under more tight surveillance.
Yeah.
So this is a new area that was not envisioned to be an outgrowth of AI.
Well, Dr. Topol, thanks again for being with us. Stick with us because we'll have our discussion session in a few minutes. Our next panelist is Dr. Susan Domchek, who is a professor of oncology at the University of Pennsylvania, at the University Hospital, Penn Medicine. She's executive director of the Bahar Center for BRCA breast cancers linked to the BRCA genes. She's also director of the hospital's McDonald Women's Cancer Risk Evaluation Center. Dr. Domchek, it's good to talk with you once again. Thanks.
Thank you for having me.
You are not a radiologist or a pathologist. You're not on the front lines, I guess, of this. From all that we've heard from Dr. Topol, how much of it or what of it has reached your office and your practice?
Sure. I can reiterate a few things that were said, but I think another aspect is that we are increasingly, as a physician and as a physician researcher, I think the tools that I'm using probably the most are the ability to synthesize information that's out there already. There is a program called Open Evidence, which allows us to search the medical literature in a way that's just much more intuitive and easier. So if I have a specific question, like how should I treat this patient in this specific circumstance, AI will generate the guidelines for me. And it's not perfect. I want to be 100% clear. It's not perfect, but it gives you references and resources. And then we use that to incorporate with our medical training and all our other knowledge base. But it is a lot easier to find information now, just so much easier. I can't even begin to tell you. So that has been probably the thing that's changed my life most day to day, is that ability to search. The administrative tasks, as mentioned, it's quite helpful for those sorts of things. There are some other elements that I'm particularly excited about. The ability not only to, as mentioned, to use AI for diagnostics, meaning to find, say, a breast cancer in a mammogram that might have been otherwise missed. We've used sort of machine algorithms for that purpose for a while in radiology. They're only getting better, but the exciting thing, as Dr. Topol mentioned, is the ability to use mammographic data to predict short-term risk. And that's different than finding the cancer, right? Finding the cancer is, okay, you've got a mammogram, it can be hard to read, and the machine is better at reading the actual image in front of you. But what we know now is that there's a lot more information in the mammogram that can actually predict whether or not you might get cancer in the next few years. Mammograms also change over time. A mammogram from 1 year to the next year to the next year, they look a little different. And so that we don't necessarily talk about that in our regular readings of mammograms, but AI can synthesize all those kind of changes. So I think from my standpoint as a breast medical oncologist and as a geneticist, that information is close in terms of how we're going to use that, which is actually really quite exciting. So that could mean better identifying individuals out there in the general population who need a breast MRI, women who may choose to take medication to reduce their risk, or even think about, in certain unique cases, preventive surgery. So those are some of the things that I see in the real short term.
We spoke last week, and I asked you about. I didn't know the name of it, but it's ambient. It's ambient listening.
Yes.
And Dr. Topol was referring to this. It's a program by which and people listening may have experienced this at their doctor's office already, where the doctor says, "Look, do you mind if I record our conversation? That way I can, I don't have to have my nose buried in the computer." And the AI program takes the recording of the conversation and distills it into doctor's notes. I gather effective ones. And you pointed out that the arithmetic on this isn't all that easy.
Well, yes, I think that this is in progress. So we've used the electronic health record for years. My notes are very what we call templated. So actually, I don't actually have to input that much information. Mm-hmm. I've also been doing this for a long time. So even though, yes, I am on the computer, I can actually finish my note while I'm seeing a patient. If you use ambient listening, you have to edit that note. So I think it is figuring out how we're each going to use this, because actually I see 20 to 25 patients a day. If I have to go back and edit all those notes and it takes me another minute or two after the visit, that's another hour. So it absolutely can save you time. It's just a matter of which types of patients are you seeing and how you're going to incorporate it. My primary care doctor uses ambient listening. I have no problems with it at all. And if that helps her save time, I'm all for it. But I do think there's a little bit of figuring out how it fits within a certain practice, and the realization you have to edit the notes. You have to go back and read them and make sure they're correct.
And that, I would assume, will be a refrain that we'll hear forever from doctors, no matter how much AI is introduced into their practice. There has to be some human review of what's going on.
Well, certainly we make mistakes too, and an argument that can be made is that we do things, that we make mistakes on our notes, and that we're not comprehensive in our notes when we make them. So believe me, I'm not suggesting. I'm not a Luddite. I do think that this is just going to continually get better, but we all have to kind of figure it out. Another way that we're experimenting with AI is that there are through our electronic health record, there are a large number of portal messages. And I don't know if you use the patient portal, but people can put in messages about anything, prescription refills, questions, and we are piloting a program where the first draft is done by AI. So far, it's not very good, but I completely anticipate that it'll get better. So everything's going to improve. Am I worried about my job? Not really, because I do think that some people will be completely fine with AI taking over their healthcare. But a lot of people, I'm a cancer doctor. I take care of people who are dealing with really serious medical problems, and I still think I'm going to have a role.
If you had a wish list of things that you would hope to see AI develop, and something that would really change the way that you practice medicine for the better, what would it be? Is there something out there that would really make your day?
Yeah, well, one of the things that to point out is AI is good uh, with churning through the information that they have. And oftentimes the problem in a health record is the information that the health record doesn't have. For instance, did someone take a good family history? Did someone ask all the questions that they're supposed to ask? So what could help us is AI making sure that those questions get answered, because a lot of delayed diagnosis or misdiagnosis is often just because all of the information isn't in front of someone for various reasons, including
Hmm.
that the healthcare provider didn't ask. We also just have to be careful that, if the medical students, when you're a medical student, you think you have every problem. You rotate through this clinic and you're sure you have a brain tumor, and then you're sure you have renal failure, and you're sure you have heart disease. And we have to be really careful about the long list of diagnoses that can be churned out as patients do their own sort of AI searches, can be challenging too. And so we don't want to miss things, for sure. And AI can help remind us that this zebra is out there. Don't forget about it. But if we put all the zebras in front of patients, that can be a challenge too. So we just have to get it right. I'm sure that we
Yeah,
will,
yeah.
and it's early days.
You're citing this evidently piece of medical wisdom that you search for horses,
Yeah, that
not
you
zebras.
start. I want to be clear. You start with the common stuff. That doesn't mean you end with the common stuff. So I think that's sometimes the challenge is that, in medicine we start with the things that, if you hear symptoms, you want to make sure that you take care of the most important problem first, and then the thing that it may really be a problem for a patient in the short term, and then you work on the common things. We don't, if there's 100 tests to send for a symptom, we don't send 100 tests at the same time. We have a process by which we go through. And again, I think AI is going to help us with that, to make
Right.
sure that we do it in the right order.
Well, Dr. Domchek, thanks for joining us once again, and stick with us because in a few minutes we'll bring you and Dr. Topol back. But we're going to turn now to our third panelist, our concluding panelist, and he joins us from Israel, where he's at the Rabin Medical Center, which where he works. Dr. Michael Bahar is head of the rehabilitation department there. The last time we spoke, it was about the impact of the war and special needs for rehabilitation that war creates. Dr. Bahar, it's great to see you again.
Thank you. It's great to be here, and thank you for having me again.
When I asked you about the impact of AI on your work, you replied, this was an email conversation, but you replied that it has applications from the very start of rehabilitation, from the first evaluation of a patient. What happens?
Yes, AI is very exciting in the field of rehabilitation, and the way that we're trying to implement it in our department in Bellinson at the Rabin Medical Center is actually focusing on the fact that we want to maximize the treatment time that we have with patients. That's the treatment time, the therapy time, is the most valuable resource that we have as rehabilitation physicians. And when a patient arrives to the rehabilitation department after an impairment occurs, okay, and it can be due to an illness or pathology or a trauma, the initial phase of the rehabilitation process is actually all the impairment assessment phase. And this phase includes various tests, okay, that we use in order to assess impairments in the physical area, in the cognitive area, in the emotional area, psychological area. So we actually need to spend a lot of therapy time in performing these tests in order to evaluate the impairments of the patient. Now, what we're trying to do, what we're already implementing, is actually the use of AI models that can perform these evaluation tests instead of the therapist, in a way that we can dedicate all the therapy sessions, frontal therapy sessions that we have, that will be focused on the therapy itself. The patient arrives to the department, he begins independently using a computer, using a tablet, starting doing evaluation, especially on the cognitive, on the speech part of the impairment. And after that, we can identify the problems, okay? And we identify the problems and the personal needs of every patient. After that, we can relatively, after a short time, we can already begin the therapy sessions based on the data that the AI collected for us. And that's a great advantage because we can maximize the therapy time that we have with the patients, which is limited. As in any rehabilitation, we cannot keep the patients forever. And the therapy time, the frontal therapy time is limited. So we need to use it in the best way possible.
You also told me that AI language modules can do very well for patients with speech and cognitive impairments.
We know that the success of any rehabilitation process depends on the time spent on practicing in the various modes that we want to practice, okay? The fact that today I can give a speech therapist to a patient that works with him for 30 minutes a day or 45 minutes a day, it's not enough to really achieve all the potential that we can get in order to improve the speech impairment. We actually trained an AI model in order to do practice sessions, independent practice sessions with the patient, so we can further practice on his speech difficulties with the AI model up in the afternoon after the frontal sessions are already done. And it's a great advantage, as I said, to maximize, to give all the therapy time needed to the patient.
How concerned are you that the time saved, say in diagnostics, will not actually transfer to time spent with the patient, but will go toward savings for the not necessarily Rabin Medical Center, but for the institution, whatever it might be.
Of course. I am concerned that, at the end, the medical institutions have financial concerns, and frontal therapy sessions is a costly practice. And that's why it's one of the reasons that it's limited in time. I am concerned that someone in the administration can have the idea, we can replace the therapist with AI models, but that will be unproductive because, as I said, we want to add therapy time. We don't want to replace it, okay? And the fact is that the therapist, the human being, is still there identifying the process, following the advancements, giving the AI model the indications of what we need to work about, and giving further time dedicated to assess the impairment of the patient. Replacing the therapist with an AI model will be counterproductive to our effort to maximize the treatment. And I believe that it's not too costly for the system to use and implement it in the department, in the medical field. So I believe that we will use it, as I said, to maximize therapy and not to replace the frontal therapy, which is essential for the process.
The past week of thinking about AI and medicine and reading Dr. Topol's book very interesting book about it, I was thinking about the quantification of information and of medicine. And it made me think about the last time we spoke when you described to me the rehabilitation of a group of soldiers who had suffered war injuries. And there was one soldier patient named Etan, who had such charisma, was your word. I remember remarking it was an unusual medical diagnosis, but he had such charisma and such a positive attitude that despite his own very serious rehabilitation issues, he managed to lift up the whole group and accelerate their rehabilitation and get them get them with the program. And I wonder, with all the wonders of quantifying that AI promises, if we're at risk of missing out on completely unquantifiable, unimageable aspects of our being, like whatever it was that was inside Eitan that made him the most effective medicine you could give these guys.
As we talked about the power of the group, okay, in rehabilitation.
Yeah.
And in the past 2 and more years, especially during working with injured soldiers in the department, we saw what you described, how they influenced one another to improve in the rehabilitation process and how much strength they gave to one each other. And I do believe that it's something that no AI model can ever replace. Okay, it's the power of the spirit, and no AI model has the spirit. So I believe that we will see it in the rehabilitation departments from all types. We will see how patients are influencing one each other. And yes, you will see those ATANs or others that we saw during the years influencing the rehabilitation of their other.
And who knows, maybe you can quantify something about him that he has. In any case, thank you very much, Dr. Bahar. And I want to bring back Eric Topol and Susan Domchek so that all of us are here for our discussion. And the first, I mean, all of you have spoken pretty enthusiastically about positive changes that have taken place and that might yet take place. I'm just curious whether that's generally the case, or is there any resistance in the profession to medicine being done in ways that weren't the way you were taught that it was done, and that aren't the traditions of your mentors? Is the profession enthusiastic, resigned, impressed, curious? What's the attitude toward AI? Dr. Topol, I'll start with you.
Well, there's no shortage of resistance for different reasons, some of which are understandable. Like a lot of things they're missing the compelling evidence. There's not the really hard data to say this is practice changing, this should be routine. But there's other things like the regulatory oversight. So a lot of these tools, these algorithms, are companies that consider their information proprietary. They often never even publish their work. And so there's lack of transparency. So how do you have a health system that buys into some algorithm and says, go ahead and use it, and you don't even know if it works, right? So there's a lot of this kind of stuff. There's, reimbursement. There's, we talked about privacy and security earlier. So there's a threat here of control. This is democratizing medicine at a much greater extent, giving patients more charge. They can do second, third, fourth, infinity number of opinions about their data and about their questions, and they can get access, 24/7. And so this is a whole different version than years ago when people would Google something and bring in a list to a doctor. So there's lots of things here that are challenging the control freak nature of physicians. It's a very turbulent situation.
Dr. Domchek, any thoughts on that?
I think there are a couple of other issues too. One is that there are things that chatbots and AI can do. For instance, pre-test education for genetic testing. They can identify people who are good candidates for genetic testing and proceed with it, except that someone actually has to order the test. And that, for instance, is a provider. So a doctor right now has to order the test. That might change over time, but right now that's mostly how it is. There's direct-to-consumer testing. But then there's issues of medical legal liability, which is an issue in the United States. Like if a chat bot gets something wrong, like whose fault is it? And like, how's that going to happen? In addition, if there's ambient listening, and again, I don't mean to make this as a very US centric thing about medical legal stuff, But if an entire session is recorded, but the chatbot sort of summarizes it in a way, but there's a thread of something in the actual recording, like what's discoverable. So there's just all sorts of issues. By the way, these are issues when doctors see patients too. But then all of a sudden, like you could get sued for what a chatbot does. That feels weird, you know, because that's not, if you will, your mistake. So that's, you know, that is one of the things. But you know what? There are a lot of patients. There is a lot of care. There are a lot of patients not getting very good care because they can't get access. So I think that we just have to be open-minded and say, how is this going to help us? Because it's going to happen no matter what. So let's figure out how it's going to help us and try to mitigate the potential harms as we go along.
And Dr. Bahar, thoughts?
Most of the concerns that I encountered so far is mostly arrived from our colleagues and in the multidisciplinary sectors, okay, speech therapists, occupational therapists, that are raising concerns about the limits and what if, as I said before, administrations will try to cut back on frontal time in order to switch to AI models. Privacy is also a concern. We saw leaks from various AI models that arrived to the internet in various ways. A lot of personal information that were already leaked from different systems that were easy to find online. So it's also one of the main concerns that we talk about in here. But I need to say that most of what I see from my colleagues in the rehabilitation field and others is a lot of, they're very enthusiastic, okay, because they see the potential of AI. We need to use it wisely. We need to address all the concerns, similar concerns as those that the other panelists also shared, but a lot of enthusiasm for the future, no doubt.
This is a question specifically about American medicine, so I'll pose it to Drs. Topol and Domchek. Is there an inevitable right now, or are we at a moment of perhaps intensifying inequality of institutions of medical care? That is, are the well-funded teaching hospitals more able to take steps forward with AI than a rural hospital, which is struggling to stay open as it is? Are we going to see greater differences in the quality of medicine that can be practiced in different kinds of parts of the country? Dr. Topol, anything there?
Well, there's no question that AI can exacerbate the pre-existing, which is pretty profound level of inequalities. But there's a lot of encouraging signs that when there's a real intent, when there are programs developed, not so much your question, Robert, about urban versus rural health systems, but more about people who have access issues, who are lower socioeconomic strata. What we've seen is programs around the world where, like for example, in the UK, they developed a mental health app that was specifically geared for people that were less likely to access apps, and had tremendous success. We've seen that across the board for eye care, specifically for diabetic retinopathy diagnosis, for picking up heart disease in various parts of the world where there's not the technology, with different types of AI. So there's many good examples now of being able to use AI to reduce inequities. So we have to see if every one of them, it was because there was deliberate efforts to take initiative.
And Dr. Domchek?
Certainly, as advances come, usually wealthy white people take advantage of them first in the United States. There is, this increasing direct-to-consumer structure of everything from genetic testing to lab tests to full-body MRI that people are paying out of pocket for. I'm not saying that's good medical care, by the way. It's just care that wealthy people are accessing. So, I agree that if we do it the right way, this could make things better because, if you will, sometimes the squeaky wheel gets the grease, as they say, and that people who know how to access the system and really ping at it. But what if we had a system where the triaging was based on AI so that we could really flag the people who most needed to be seen first, right? That would be wonderful. And right now, again, the phones ring all the time. The messages come through, through the portal. We have to recognize that right now, a lot of people in the United States are not getting great medical care because of these issues of access and triage and being able to pull out the people who most need care first. So we should try to be thoughtful and deliberate about it.
I have a question for Dr. Topol. Since you've been writing about longevity, does more AI in medicine promote longevity potentially and give us more of us a crack at hitting 100?
That's a thesis that I advanced in Superagers, and the reason I wrote about that, and I'm excited about it, is I actually think extending health span will be the singular greatest achievement of multimodal AI. When I say multimodal, for each individual, bring in all their layers of data, whether it's not all their electronic health records, and they're not just, of course, the traditional things like the labs and the scans that can be subject to AI separately, but then now the proteins, these up to 11,000 proteins that give us organ clocks and all sorts of biomarkers, as we have now for up to 20 years in advance for Alzheimer's, and genetics and exposures and on and on and on, sensors. So when we have all that data, the whole idea is that we can predict, and we've seen some remarkable examples in recent months. We can predict a person's health arc 20 years in advance for basically all diseases, over 1,200 diseases. And when we can predict, that gives us the path to prevention. So this is why I think, and we're just starting a prevention of Alzheimer's trial in high-risk people, because that possibility, which never was there before, is now come to fruition. So we are excited about prevention now more than ever before. And as you know, medicine today is practiced as treatment. There's very little prevention. AI, no human being could assimilate the billions and billions of data points that AI can. This is a sweet spot for use of AI. And we're seeing now some great results. In fact, just last week at Stanford, James Zoe and his group showed that sleep data from a sleep lab, 65,000 people at the Stanford Sleep Lab, it helped beyond the electronic health record to accurately predict in the future 130 diseases like heart attacks and heart failure and cancer and all sorts of things. So when you have the data and it's integrated and you have AI, you can do some pretty remarkable things.
I'm just curious, how is data integrated today? Let's say, Dr. Domchek, we had a mention earlier that a mammogram can be analyzed and it can be shown to indicate, you said, was it heart disease that would be implicit in a mammogram? Would that information from a patient of yours make it to some cardiologist? And how would that happen?
Sorry, my audio wouldn't go on.
Yeah,
I think that these are some of the outstanding questions. How are we going to actually use this clinically? How are we going to make sure that it gets streamlined appropriately? So, this is still sort of early days for that type of work. And again, the ultimate goal in medicine is to prove that you can impact patients' care. So it's not sufficient to say that something predicts something. It has to show that it predicts it, that you can do something about that changes the outcome, right? So you have to kind of like go the full circle. So right now, I think it's really exciting that we have these things that can predict this, but we also have to make sure, there's all sorts of concepts in medicine like lead time bias and length bias, and whether we're giving people a diagnosis that doesn't matter right now. Like we have to be able to show that knowing this changes the outcome. And I think, I think we'll get there. But yes, there's a lot of potential for care to get missed or not integrated. It has to be across a whole system because I'm not a cardiologist. And so, I would need to make sure that my primary care doctors and my cardiology colleagues we're all together in this process.
Dr. Bahar, you practice in a much smaller, more compact country. Israel was practically a laboratory for COVID vaccines because its numbers were so well collected. Do you experience these same issues there?
In Israel, we actually have a unified information system that collects data from all the hospitals, all the clinics, all the various HMOs. And for me, as the physician of the patient at that moment, I have access to all this data. The problem is that it's an overflow of data. Sometimes I open the computer system and I see dozens, if not hundreds of documents, and it's obvious that I cannot look at all of them. I cannot go through all of them. And I'm waiting for the AI model that will know how to collect all this data and to create it, to summarize it in a way that is effective during a clinic visit or even during admission to the department. It's very important, but we do see it. It's a big data problem. And I know that the Israeli Health Ministry and the various HMOs are already working on models that will know how to collect all of it. I will keep you informed because it will be the next step.
Could you have an AI program that would prioritize all that information so that
that's the goal? That's the challenge.
That's the challenge. That's the challenge. Yeah. Dr. Topol, in your book, you wrote about the problem, the black box problem, that something seems to work, but it doesn't. You don't know why it works or how it works. My impression was that people didn't know how aspirin worked for a century or more, but they were using it because they could see that it worked, and that one difference between medicine and biology, I think, was that if the aspirin helps people, use it. Somebody else can do the experiment to figure out why. Are there going to be a lot of black boxes that we'll have to learn to live with here?
Well, you're bringing up two important concepts. First is that we tend to hold AI to a much more level of explainability than we do things that we use in medicine all the time. We still don't really know the mechanism of aspirin. We have lots of ideas, particularly for certain use cases, but we have no idea for how anesthetics actually work, how electroconvulsive therapy for severe depression. I could go on a long list of we don't know how it works. But then for AI, we want to know exactly how it works. Well, it turns out the ability to deconstruct these models is getting better and better. Various things, so-called saliency maps and masking. And so we are going to get some more explainability as an outgrowth of that effort. But there will be times it's not fully explainable. And your point about if it really works, if it's unquestionably, incontrovertibly working and lacking hazard, then it would be accepted. So explainability is a goal, but it may not ever be one that we should expect 100%. So that I think is the black box has been a big argument, but I think over time we're starting to see a little bit of less demands for that full explainability.
Do you have any black boxes in your practices, Dr. Domchek or Dr. Bahar?
Sure. I mean, it's, we, for instance, it would be really nice to know in patients with metastatic breast cancer, we give the same type of patient the same drug, and some respond and some don't. And so these are all things that, and that can be really frustrating to patients. We know on average how many patients will respond. We don't know the individual, in front of us. So yes, anything that can make us better is great, but there's a lot of things that we thought would make things better that didn't. So you have to test it. You can't assume that just because it's flashy that that it's going to work better. You have to test it just like we've tested everything else, and those studies are ongoing. And again, I think it's optimistic, and it's only going to get better. I mean, I'm curious, for the other panelists, one thing that is true is that AI is learning from what's out there, but we've provided that information to it, right? So we still have to do research and provide that information going forward. AI can't do randomized clinical trials, at least not yet, I don't think. So we have to continue to provide the data by which AI can interpret the findings.
You're nodding in agreement.
Yeah, absolutely, because I completely agree. Okay, in order to improve AI all the time, we need to give it more data. We need to teach it, okay, what we're doing and the results of our studies. And that's a very important thing that will never go away, because that's the way it will be a more effective tool. Absolutely.
Well, you've all taught me a lot in the past hour and in the time preparing for it. Thank you very much to all of our guests. That was Dr. Michael Bahar, also Dr. Susan Domchek and Dr. Eric Topol. And many thanks to Joshua Plout and Roni Giuliano of American Friends of Rabin Medical Center, which produces Global Connections. And also thanks to our technical director, Bobby Grandone. Our program sponsor is the American Friends of Rabin Medical Center. It's a 501c3 national charitable organization which represents, in the United States, Israel's largest hospital, Rabin Medical Center in Petach Tikva. It's in Greater Tel Aviv. The website is www.afrmc.org. I'm Robert Siegel, and this has been Global Connections, Navigating the New Normal. See you next month. Stay healthy and stay safe.